Welcome and good morning this last day of September of 2023. Welcome to the Batey Research Appreciation event. We have Gail Batey here with us this morning, and I will introduce her a little bit later. There you are. Good morning, Gail.
Right.
First, I'm Helena Chui. I've been the director of the USC Alzheimer's Disease Research Center for about just short of 20 years. And we want to thank all of our participants in the ADRC and its affiliated studies. Today, the theme of our presentations, let me share screen. I'm still not able. I'm still not able to share my screen. There we go. Fantastic. The theme of today's Batey Research Participation Day is first disease-modifying treatment for Alzheimer's disease is here. So I've been in the field for almost 40 years, and we've been doing our best to help people maintain quality of life. But in all honesty, all we've had so far are symptomatic medications and a great support team and community. But this year, the FDA, the Food and Drug Administration, gave full approval to a disease-modifying treatment for Alzheimer's that alters one of the two key biomarkers for Alzheimer's disease, namely amyloid, and shows efficacy for patient function. So this is the first DMT for Alzheimer's disease, and we are entering a new era, just beginning to break the sound barrier. And I hope by the end of the day, you will share with us this excitement, but also understand what this medication can do and what so far it does not do. It's not a full cure, and the things that we have to watch out for in terms of side effects. And I hope we'll provide some practical information about how you can determine if you or your loved one qualifies for this new disease-modifying treatment. During the webinar, the Zoom controls for your video and microphone will be turned off. But we really would like you to type in your questions into the chat box under Q&A, type in your question, and our panel of speakers will be trying to answer you throughout the program. We are one of 38 Alzheimer's disease research centers that are funded by the National Institute on Aging, which in turn is part of the National Institutes of Health in Washington, D.C. The USC ADRC was among the first 5 of these 38 centers founded in 1984. So we are just short of 40 years. At USC, we're also part of a state of California that funds 10 California Alzheimer's disease centers, and 2 of these state centers are also at USC. The mission of the USC ADRC is to provide researchers locally and throughout the country with special resources to accelerate the knowledge of Alzheimer's disease and related disorders. Our USC ADRC focuses, as you heard in the video, how vascular, metabolic, and genetic factors contribute to risk and prevention of Alzheimer's disease, particularly in underrepresented populations. We also provide participants with access to leading-edge studies, such as promising medications and treatments. And today, we want to share some of the things that we've discovered, and this would not have been possible without our participants. And we hope you know how much we appreciate you. This is our partnership with you. All of the ADRCs have a common structure. There is an administrative core, a data core, an outreach, recruitment and engagement core, the OR core, a clinical core, which interfaces with all of our participants, an imaging core, where we have MRI scans, biomarkers, which are studying bodily fluids, plasma, which is from blood, and spinal fluid. And then a brain research, a brain donation, neuropathology core, where we're studying just invaluable brain tissues from persons who have passed away. We have a research education component to mentor the next generation, and development projects to help beginning investigators to get seed data to start their own more developed research projects. We also have many affiliated clinical studies, which are observational or clinical trials, and we participate nationally with many multi-center trials. I'm Helena Chui. I'm one of the three multiple principal investigators, together with Berislav Zlokovic and Arthur Toga. You will hear presentations today, first from Dr. Hussein Yassine, who leads our research education core, and also has a new center for personalized brain health, which focuses on dementia prevention. You'll also hear from John Ringman, who will give us the background for the new disease-modifying anti-amyloid treatments, from Liz Jo, who will give you an overview of the current status of the art for diagnosis and treatment. Then we are very fortunate today to have Lon Schneider, who is an international expert on clinical trials, who will give us the scoop on the DMT treatment. Nasim Sheikh-Bahaei, a neuroradiologist, will talk about the most common side effects from this medication, lecanemab or Leqembi. I will come back and talk about the practical aspects of obtaining treatment from lecanemab at USC, and Maria Aranda, the director of the OR, will thank you again and give you the view of how much we value you as participants and partners. Translational research is a big part of the ADRC mission, and you may have heard this term in translating findings from the laboratory bench to the patient bedside. This is a two-way interactive process, and we will hear talks from John Ringman that start even about what we found in Alzheimer found in human brain tissue, how we're using biomarkers from blood, spinal fluid, and imaging at the bedside, either in observational studies and clinical trials. To get to treatment, there are clinical trials that involve research participants, and many of you have been involved. And then if there is efficacy and safety, and finally FDA approval, then research can lead to actually new treatments in patients. And that's where we are today, talking about a new disease-modifying treatment for Alzheimer's disease. Now, our appreciation is codified and exemplified by our gratitude to Ben and Gail Batey. And we're most fortunate that Gail has been with us through all of these research participant days. Ben and Gail built nearly 1,000 homes in Bakersfield. And one of Ben's greatest pleasures was seeing families live their lives in the homes he had built. He would often drive by those neighborhoods. But one of his most proud legacies was mentoring young builders and helping them get started in business. Unfortunately, as many of you have experienced, Ben was diagnosed with dementia. But he and Gail did not sit on the sidelines. They immediately started to support cutting-edge research that would change things for the better and for the future. After Ben passed away in 2014, Gail and the Batey family continued to support the work of several investigators, in particular, Ralph Langen, a physical chemist who studies how proteins like amyloid and tau misfold, and Hussein Yassine, who will be our first speaker this morning, whose research focuses on apolipoprotein E4. Ben donated his brain to research, and Gail wants to make the experience of families that participate in the brain donation program a seamless and supportive one. So she has been donating personally to our ADRC brain donation family liaison. Ben and Gail have always rolled up their sleeves to break new ground and to build the character and skills of the next generation. And when I've gone up and had the pleasure of having lunch with Gail and meeting the kids, now grown and part of the Batey Family Foundation, I can truly see that Ben and Gail instilled the character and skills in their own next generation. This from the last year's 2022 Batey family. Want to thank you, Gail, for support that you and Ben have given us beginning in 2012. I remember bringing you to Ralph Langen's lab and Dr. Langen talking about how amyloid folds, how it misfolds, and immediately you raised your hand and you and Ben made the first of many donations to Keck research. So Gail, I think you're on. Just want to thank you personally for being here for us and being there for Ben and for families.
Should I speak now, Dr. Chui?
You may say a few words, Gail. They would be very, very welcome and appreciated.
Okay. Well, thank you for all the kind words. I would just say that my experience with USC, with the Keck School of Medicine, has been a very positive one. And there are people there who not only are brilliant, but they care about people. And I would encourage anybody who's considering it today to join, to be one of their participants in a study, to do that, because that's how we're going to solve this problem.
Thank you so much, Gail, for that very heartfelt and personal message. So without further ado, let's move into the program. I hope all of you got your program brochure with bio on each of the speakers. Our first speaker this morning is Dr. Hussein Yassine. And I've known Hussein for the last decade. We've known for several decades that the major risk factor for Alzheimer's disease is apolipoprotein E4. It's a mouthful. He's going to tell you more about it. He is a true expert in lipid metabolism, fatty metabolism, and apolipoproteins. Hussein?
Thank you, Helena, and thank you everybody for joining us this morning. My name is Hussein Yassine. I'm from the Department of Neurology at USC, and I'm very excited to talk to you about our research and the concept that, yes, we can slow down Alzheimer's disease. There is hope, and we've got some good ideas on how we can do that, and I hope that this presentation would be of benefit to you. So throughout this presentation, I'm going to talk a brief introduction to Alzheimer's. ApoE4 is a genetic risk factor. It's a copy of a gene that increases the risk, and I will be talking about that for a minute we're very excited to start the new center of USC, the USC Center for Personalized Brain Health. And finally, the last part of this talk is what can we do to reduce the risk of Alzheimer's? So really, the essence of this presentation is prevention. And throughout the meeting today, you will hear from outstanding speakers on other aspects of management of Alzheimer's, which is treatment. But for my task, it's going to be prevention. So some of you may already know this. Alzheimer's is an irreversible, progressive brain loss disease where it slowly destroys memory and thinking. Typically, the symptoms appear after the age of 60. It's important to understand that Alzheimer's is not part of normal aging. People are not supposed to lose their function as they age. And one of the first signs of Alzheimer's is memory loss. Alzheimer's is a big problem. It's one of the most common causes of dementia among the ages of 65 and above. We estimate that around 6 million people in the US have been diagnosed or will be diagnosed with Alzheimer's. And by 2050, if we do not come up with new medications, it's going to be 16 million people. So it's a huge problem. And we're racing against time to develop new therapies and new biomarkers to diagnose this disease and limit its impact. So one of the things that you might hear throughout the day is that Alzheimer attacks specific areas in the brain. And in this picture, you see the hippocampus. The hippocampus comes from the Greek word seahorse. And the seahorse-like structure in this region of the brain is affected early in patients with Alzheimer's, and changes can appear up to 20 years before the symptoms start. So what is ApoE4? ApoE4 is a gene copy, and as you know, we inherit 2 copies of genes, one from mom and one from dad. If mom has 1 copy, then there is a chance that you might get 1 copy. But if both mom and dad have a copy of E4 and you inherit those 2 copies, then you would be what we call a homozygote, meaning having 2 copies of E4. If you have 1 copy, the risk increases up to 4-fold. But if you have 2 copies, the risk of Alzheimer's increases 10-fold and above. What's more important is that more than 50% of patients with Alzheimer's disease have 1 copy of E4. So as you heard in the videos before this symposium, it's indeed the elephant in the room. So one of the things that I want to highlight in this talk is that we now know, and we've known for almost a decade and more, that the brain changes in patients with Alzheimer's or ApoE4 Alzheimer's decades before. And as you could see in this graph, we can stain or view amyloid by using something called amyloid PET scans. And in this case, the red color is where the amyloid is depositing in the brain. And by actually doing amyloid PET scans in population cohorts, we know that if you are an ApoE4 carrier, you might be accumulating amyloid 20 years before the symptoms start. So to us, this is a sign that disease can be possibly identified and, more importantly, modified up to decades, 2 decades before the symptoms can start. So there is a big problem. ApoE4 is a big problem. 25% of the population has 1 copy of ApoE4. It's inherited, and this effect of E4 in the brain appears very early in life, and it affects how the brain is developing, and later on, it increases the risk of dementia. So we have a task on hand to try to come up with solutions for everyone who carries ApoE4. And for that, USC has helped us launch the USC Center for Personalized Brain Health. And this new center that's about to start will focus on identifying the best recommendations and coming up with the best recommendations of what an ApoE4 carrier should do before the disease develops or after the disease develops, providing essential resources to decrease the risk of Alzheimer's disease. These can include biomarker studies, imaging studies, lifestyle interventions, or even drugs and treatments, as we are going to see toward the end of this talk. Let me show you some of the studies we've been doing. Over the past year, we have launched USC Gene Screen, and this is an ambitious program where we want to build a cohort of more than 1,000 ApoE4 carriers from the Los Angeles area. This is a very robust tool where you go in, you put your information, and if you are eligible, you would receive a kit, a salivary probe where you would mail, and then we will find out if you the gene variants that you have at risk for Alzheimer's, and you would be enrolled in the Alzheimer's studies at USC. So we're super excited to develop the USC Gene Screen tool to help identify risk of Alzheimer's and grow our tools against this disease. I want to highlight one study that my group have done in the past 6 or 7 years, and this is the omega-3 brain study. Some of you might have participated in the study, and we're very grateful that you did. The omega-3 brain study has not been reported yet. It started in 2018 and will finish in 2024. About 368 people were randomized to take the omega-3 DHA versus placebo, and the goal of the study is to figure out whether high-dose DHA supplementation has a role in slowing down the pathology of ApoE4 before dementia starts, and hence the name Prevent E4. So let's move on a little bit to talk about risk factors for Alzheimer's disease. And we talked about genetics like ApoE4, age above the age of 65, low education, head trauma, and there are lifestyle factors that can actually be used or controlled to reduce the risk, including diet, sleep, exercise, chronic diseases, obesity, diabetes, high blood pressure, high cholesterol, sleep problems, heart disease, strokes, hearing loss. And at USC, we have a very active group studying pollution and dementia risk. So let's talk about diet. If you were to ask me, what would be the best diet for the brain? Well, we've got some good evidence that consumption of plant-based diets, such as fruits, berries, apples, oranges, and grapes, beans, and green leafy vegetables, having 1 serving of fish per week, whole grains and legumes, cutting down on simple sugars from soda and juice, good fats such as olives, olive oils, and nuts, and avocados are another example, reducing salt intake. If we can stick with a diet like this one, especially if we can start during middle age, we have a good chance of reducing or slowing down the progression of this disease. My lab is specifically interested in omega-3s, and we've been studying them for almost a decade now. And you could see from this figure that the recommended consumption of this omega-3 DHA should be around 200 milligrams per day, but the average US individual is only consuming half as much, 100 milligrams. That translates to at least 1 or preferably 2 servings of fatty fish per week. We recommend people to consume that amount. Some of you may not have access to fish or may not like fish, and it may not be a bad idea to get an omega-3 supplement if you are not consuming enough fish. However, the data with seafood consumption is stronger than the data with taking supplements. Exercise has really an important role in dementia prevention. Exercise can take the shape of strength training, like knee extensions, flexions, upper and back muscles. It can take the form of postural balance exercises with each training. And of course, it could also include aerobic exercises such as walking, jogging, being in the pool, or doing some gymnastics. It doesn't have to be quite complicated. It could be very simple, but we know that exercise is really important. We cannot isolate lifestyle without talking about depression and loneliness. We know that depression and loneliness lead to faster cognitive decline. More social activities can bolster or improve cognition, and it's very important to be socially connected to help the brain stave off diseases like Alzheimer's and lower our stress levels. So we recommend for our patients good sleep, meditation, praying, music, stimulate the brain throughout the life by engaging in socially and intellectually active activities. Brain training games have not really panned out by scientific studies. Hearing aids when needed, and we recommend weight loss for patients with obesity during middle age, but maintaining body weight for those above the age of 75, because weight loss later in life could be a risk factor for dementia. So it's also important to treat chronic medical conditions such as hypertension, obesity, diabetes, thyroid, depression, sleep apnea, and others. One of the risk factors is a low vitamin B12 or elevated homocysteine levels, and we recommend taking B12 to those with elevated homocysteine levels. And the real important concept that I want everybody to know is if you know that you are carrying ApoE4, the time is now. The time is as soon as possible, because intervening during midlife has a stronger impact than intervening later in life, but it's never too late. So we launched in 2023 the AD Prevention Clinic, where we are happy to see people who have been identified with increased risk due to ApoE4 or other genetic risk factors. We will work with patients to focus on managing vascular metabolic risk factors, and our ultimate goal is to prevent or delay the onset of dementia. And if you or somebody you know are affected, we are happy to help. And I cannot thank Gail Batey enough for all her faith and support in our work. This is the lipid analyzer that Gail Batey helped donate to USC that we have used in our research trials and research studies, and we're bringing cutting-edge research about brain lipids due to this very generous donation. I thank all the patients, the funders, and everybody for supporting our work at USC.
Thank you, Dr. Yassine. We have 5 minutes for questions.
There are some that have been posted in the chat.
Okay, John, would you go ahead and lead off?
Well, the questions in the chat are regarding ApoE, so perhaps Hussein could take them, or do you want me to start my presentation?
No, you could maybe either read them. Could you read them to Dr.
Sure.
Yassine?
So a question is, so is apolipoprotein the same as lipoprotein A?
The answer is no. Lipoprotein little a is a new genetic risk factor that is not very new, but it's a risk factor for cardiovascular disease. It's not the same as apolipoprotein E.
Another question. So the Mediterranean or DASH diets are best? Question mark.
I wouldn't say that there is one best diet. The Mediterranean or DASH diets are good diets. Really, the goal is to avoid as much as possible processed food and to eat more plant-based diets that are rich in good ingredients. It doesn't have to be a Mediterranean diet or a DASH diet. It can be whatever is affordable or available to you.
Can ApoE4 appear in people if neither parent has this gene?
It's very rare to have a spontaneous mutation where ApoE4 can appear without parents having the gene. It is possible, but it's very rare.
So I have one ApoE marker. What should I do?
Well, first of all, I would say there's no reason to panic or be stressed out. We've got, good information out there. I think protecting your brain by the recommendations that we've provided today, whether it's diet, lifestyle, sleep, or exercise, and starting that as soon as possible would be my best advice to you. And if you have more questions, we're happy to see you in clinic.
I have a history of Alzheimer's in my family, but I have not yet been tested for the gene. How might I go about getting genetic testing? Also, can you please share the phone number again for the AD Prevention Clinic?
Okay. So maybe can somebody put the number on I can try.
I've done it.
Okay. So So the question is, how do you get genetic testing? You can ask your doctor to order the ApoE gene. Quest provides this service. USC Labs provides this service. But bear in mind that knowing that you have ApoE4 will require genetic counseling. It's not doom and gloom. There is hope. And I firmly believe that knowledge is power. So knowing that you have ApoE4 may help protect you if you follow good and balanced recommendations. But there's no guarantees, of course. But I firmly believe that knowledge is power. Not everybody needs to know. So we totally understand that some people prefer not to find out, but there are ways to figure out if you have ApoE4 or not.
Right. Important question. Do participants find out if they have 2 copies of ApoE4?
Participants in research will not normally find out if they have 1 or 2 copies of ApoE4 because we don't have genetic counseling resources. However, if they are very interested, they can get it as part of a clinical visit that will entail counseling.
I have ApoE4 homozygote, 2 copies, and have high cholesterol. Do you recommend statins? I have avoided these.
So yes, it is known that having 1 or 2 copies of ApoE4 associates with high levels of cholesterol. The clinical recommendations of statin or not use of statin is a recommendation between a doctor and patient and on an individual level. So we prefer not to provide generic recommendations without reviewing a case-by-case basis.
Been reading that statins are being overprescribed and may possibly be lowering the fats too much, especially in the brain, ?
There's no evidence that statins affect the fats in the brains. This has been well studied over 20 years now. Statins work on the liver. The brain has its own mechanism of forming fat. In fact, part of the reason why people are more aging today than maybe 50 years ago is because of statins. They are healthy, or maybe they are good drugs, but they cannot be given in water to everybody. They have to be given to people who will benefit from their use.
Please quantify how much exercise one should engage in.
Well, my common recommendation is not being a couch potato. It doesn't have to be 30 minutes a day, 5 days a week. That's the ideal. But just by moving moving in the house is much better than being a couch potato. And the more exercise you do, the better. Of course, the actual benefit from exercise is not linear, meaning that people who exercise a lot don't get the same benefit as people who don't exercise and exercise a bit. So the message is as much as you can.
Roughly half of people with Alzheimer's have ApoE4. What percentage of people with a single copy of ApoE4 will normally develop Alzheimer's?
That is an excellent question. The number is around 6% increase in the risk of Alzheimer's with 1 copy of ApoE4. So that means that a lot of ApoE4 1 copy carriers will not get Alzheimer's.
Have any other APO numbers been shown to be protective, such as ApoE2?
Yes, ApoE2, which is uncommon, is protective against Alzheimer's disease. However, ApoE2 might also be associated with other diseases. So we have to be careful about, how to interpret these gene variants.
If my dad has Alzheimer's, but my brother tested negative for ApoE4, does it mean that I do not have the gene too?
No, it doesn't, because, by way of Mendelian inheritance, it depends on if your dad had ApoE4 or not, and the chances of giving it to you or to your brother might be different.
What about ApoE3? ?
Yeah, well, we know that maybe 50% or so of patients with dementia have ApoE3. So that doesn't mean that you're protected, but it also means it's less risky than carrying ApoE4.
I can't tell what. I'm not sure. Something happened. Some of these disappeared, so I don't know what's the new ones are.
What is the risk if you have 2 copies of ApoE4?
So the risk of getting Alzheimer's increases about up to 12-fold. But I have to say that in my clinic, I see, I would say, a good number of ApoE4 homozygotes in their late 70s who do not have dementia. So there's always hope.
And yes, to everybody, our team of Alice and Tara will make available copies of our slides, and they will send out videos as well. So wonderful question and answer. Why don't we move on? And,
I would encourage Hussein to stay on because as questions come in, he may be the most qualified to answer them as well.
Yeah, that's great. If you could still manage the chat, Hussein, regarding ApoE and prevention questions, and other panelists may chime in as well. So, John, it's great you're there. Thank you, Hussein. Dr. Ringman is the Helene and Lou Galen Endowed Professor of Clinical Neurology at Keck School of Medicine. He's the chief of our Division of Memory Disorders. His own research focuses on the more rare familial autosomal dominant mutations type of Alzheimer's, but I've asked him today to give us an overview. So, John, take it away.
Thank you. And I'll try to make the transition from what we've known about amyloid and ApoE and Leqembi, with more to be said about Leqembi later. Thank you, everybody, for attending and participating in all our studies. And thank you, Ms. Batey, for all the support that you've given us. So I'm going to talk about what is amyloid and why do we care? Because there's been a lot said about amyloid, but what does that mean? So I'm going to first, what is Alzheimer's disease? That's been covered somewhat, but I'll elaborate on that. And then talk about the amyloid hypothesis. That is the avenue of research that has led us to the currently available disease-modifying treatments, such as the anti-amyloid immunotherapy like Leqembi. So why Alzheimer's disease, right? He doesn't own the disease. He didn't have it, I don't think. But why does it bear this man's name? Well, in 1907, Alois Alzheimer, who was actually a psychiatrist in Germany, described a patient who was 51 years of age and had progressive change in her behavior with delusions and cognitive decline. So he was the one that, after she passed, he made the link between this clinical presentation, this dementing illness, and the neuropathological changes in her brain. So he described what he termed miliary plaques and neurofibrillary tangles in her brain that really defined the disease. So here's one of his slides. We didn't have at the time a way to identify specifically what these plaques were, but with these silver stains, you could see them. So there wasn't a lot of change in the field until the early 80s, when these plaques in the brain were found to consist largely of a specific protein that was termed amyloid. Interestingly, around the same time, the same protein was identified as a constituent of small blood vessels in the brain in people with Alzheimer's, but also in people with Down syndrome. So this deposition of amyloid in the walls of blood vessels is termed cerebral amyloid angiopathy, or CAA. So I'm going to return to CAA. It's a very important concept for you all to know. It's rather the deposition. We think of amyloid as the amyloid plaques, but this protein also deposits in the walls of blood vessels to various extents in different people with the disease. Now, we knew at the time that Down syndrome is caused by inheriting 3 copies of chromosome 21. So the fact that this basically Alzheimer's disease pathology, the plaques and the CAA, were found in essentially all people with Down syndrome when they reached a certain age, really suggested there was something on chromosome 21 that might be driving this illness. So this is a picture of the plaques, and as we now see them, this is that represents an immunostain. That is a staining with an antibody that specifically identifies a sequence of amino acids that defines amyloid. So here you see the plaques. Okay, this is a piece of brain tissue. Here you see the amyloid deposition in the form of plaques, but also in the walls of blood vessels. So here in the walls of blood vessels, this is what we call CAA. So we can't see these plaques or the CAA with MRI scans directly. But in the last, I guess now 25 years ago, this PET technology was developed such that we can now see the plaques in the brain while people are alive. So what you do is you inject folks with a radioactively labeled molecule that binds directly to this amyloid pathology and allows you to see it. So these are two different tracers used, PIB and florbeta-PIR. These are negative scans, and these are positive scans. It takes a bit of a trained eye, but you might appreciate that there's more signal in the outer parts of the brain, the cortex, in the Alzheimer's patients than in the controls. So the CAA cannot be directly visualized yet. They're working on ways to do that. But one way they manifest is with tiny microhemorrhages in the brain. So this is a person that undoubtedly has CAA, and these little black spots, if you can see them, represent tiny little bleeds, which, like I say, is a manifestation of CAA. So subsequently, after the identification of the amyloid protein and this link with Down syndrome, 3 genes were identified, mutation of which causes a rare, highly genetic form of the disease. These are stronger genes than apolipoprotein E. They're basically determinate. That is, if you have this mutation, you unfortunately are essentially certain to develop the disease. When they identified these genes and looked at what these variants that cause the disease do, how they change the function of the normal gene, it was recognized that all of them affect APP processing. That is the processing of amyloid precursor protein. That is the protein that constitutes the plaques, the protein from which that's derived, right? So, and including the APP gene itself. So the fact that all of these genes, mutation of which causes the disease, all affect this amyloid processing was really strong evidence that amyloid plays a critical role in initiating Alzheimer's, that it has a central role in causing it. Furthermore, Hussein has already talked a lot about apolipoprotein E. And apolipoprotein E, though we're still trying to understand completely how the 2, the 3, and the 4 differ in function, at least one way they differ is the way they handle amyloid. So amyloid, the way that apolipoprotein E affects Alzheimer's risk is also likely, at least in part, related to its effect on amyloid. I won't go over all of this because Hussein already has, but I will draw your attention to this, that it's been repeatedly shown, in addition to increasing one's risk for Alzheimer's, the ApoE4 allele also increases the likelihood of having amyloid angiopathy. That is, it increases the risk of having this amyloid deposited in the walls of blood vessels. And that's important with regards to these, to Leqembi and other anti-amyloid treatments. So just to try to make the picture as comprehensive as I can, now there have been multiple different genes, variants of which contribute to Alzheimer's risk. Okay, none are as strong as the autosomal dominant genes that cause the disease, but they all increase all these variants in all of these genes contribute, at least to some degree, to the risk of Alzheimer's. Now, the function of these genes really are varied, right? These genes have roles in cell trafficking, that is how neurons move proteins in and out of the cell. They have roles in inflammation and fat metabolism. So there are clearly other things going on in the pathology of Alzheimer's disease. So back to the amyloid hypothesis, if we think that amyloid is really a driver for the disease, How can we treat that? How can we reduce the effects of amyloid? Well, many approaches have been tried. One is to decrease this production, right? You can inhibit the degree to which amyloid is APP is made or APP is cut into its different constituents. You can decrease the ability for these protein fragments to clump together in the form of plaques or CAA, or you can help the body eliminate amyloid. Now, there are different things that have been attempted, but there are immune therapies have taken center stage. So what's an immune therapy? Well, one approach that was used early on or tried early on was active immunization. That is actually stimulating people's, as you would with a vaccine, you stimulate people's immune reaction, their own immune systems to react against this protein. That actually looked like it is effective in clearing amyloid out of the brain, but essentially caused an encephalitis in too many people. So now we've gone to passive immunization. So what is passive immunization? That is, rather than activating a patient's own immune system against amyloid, you're actually administering the antibodies themselves. That's infusing them intravenously or intramuscularly, but currently intravenously. So this is where what Leqembi and the other treatments coming down the pipe, most coming down the pipeline imminently are about. There are also other approaches being studied, but I won't talk about those today. So before Leqembi, there was aducanumab or Aduhelm that was approved. Now, why was it approved? Now, these antibodies clearly, we knew this from the very first trial of an intravenous antibody, that these antibodies do clear amyloid plaques from the brain, right? So here's scans, exemplary scans of patients at baseline with their lots of amyloid in the brain, and after 1 year treatment. This is with placebo, and as you see with increasing doses of aducanumab, there is clearance of amyloid out of the brain. So that's wonderful and amazing, we think. Unfortunately, however, this degree of amyloid clearance does not correspond to a dramatic effect on the disease process. That is, there is a slowing of the progression of the disease, apparently, but it is not huge. So I'll give you one example. This is Aduhelm, in which the data is not as good as it is for Leqembi. But what we have here is this is increase in a increased scores are worse on this test. This is a test of a battery of memory and other aspects of thinking given to people at the beginning of the study and then at 78 weeks. So this is a 1.5 year study. The gray line is people treated with placebo, right? So higher is worse. And these are treatment groups, different doses. And the cognitive decline is less in people treated with the drug. And this is a real and statistically significant effect. But it is not a huge impact. We're talking about 2 points on I think this version of it is in like an 80-point scale. So it is a real effect. It does slow the disease, but not adequately as far as what we hope to do with treatment of Alzheimer's. Now, what are the potential downsides of anti-amyloid immunotherapy? The big ones are amyloid-related imaging abnormalities, or so-called ARIA. That is, these medications can cause swelling of the brain or edema, sometimes called ARIA-E, or even hemorrhages or bleeding in the brain, or ARIA-H. Now, Dr. Sheikh-Bahaei will say more about these abnormalities, but for now, these changes in the brain are usually asymptomatic, right? So if you stop the drug, the edema will go away. Okay. However, sometimes they can progress and can cause neurological symptoms, or even which may be temporary, but may not be. But that's the small percentages of the cases, and we'll talk more about that. We think that these effects of the antibodies are due to actions of the antibodies not against the plaques, but against the deposition of the amyloid in the blood vessels. That is the CAA. That is, if you have amyloid in the walls of blood vessels and these antibodies are attacking that you're weakening the walls of blood vessels, causing the brain swelling and then potentially the hemorrhages. Now, because people with ApoE4 allele are more likely to have CAA, that these it's clear from the results of the study that these adverse effects of the immunotherapy are more common in carriers of the ApoE4 allele, and even more so in people who have 2 copies. So these are pictures of the ARIA. This is the swelling of edema. These are tiny hemorrhages you may not be able to see here. But again, Dr. Sheikh-Bahaei will say more about these. So if amyloid causes Alzheimer's disease, why do these antibodies that clear amyloid out of the brain not work better? Okay. Well, amyloid appears to play a key role in triggering Alzheimer's, but other processes are involved downstream, that is leading things that actually lead to cell death and loss of neuronal connections. So for example, loss of cell integrity, the neurofibrillary tangle, which you see here, these are more closely associated with cell death, and preventing their formation and cell death is a key goal. And currently there are anti-tau antibodies being studied, which is a constituent of the neurofibrillary tangles. But as I mentioned in all the other genetic risk factors for Alzheimer's, that these are some of the processes they implicate, right? So these are no doubt things that are also playing a role in causing the disease, and which might be addressed with future medications. So I think that's my presentation. I'll see if there are questions here.
We'll hold off. Thank you, Dr. Ringman, for giving us that landscape view of Dr. Alzheimer, the history of discovery of amyloid plaques and tau-bearing neurofibrillary tangles. Let's move on, though, to our next speaker, Dr. Joe, and then have questions and answers for the 2 of you together. So Dr. Joe, Liz, is assistant professor of neurology. She did her neurology residency and behavioral neurology fellowship at USC, and now she's a clinical scholar in our Clinical Translational Science Institute. She holds a KL2 award and just got her first NIH KO3 award. She sees patients in the memory clinic. She is really our lead neurologist in our normal pressure hydrocephalus clinic, and many of you have seen her as well as Dr. Ringman, in our ADRC research studies. So Dr. Joe will talk to us about, where are we now in terms of just practical diagnosis of Alzheimer's disease and related disorders.
Make it slideshow. Thank you. It's an honor to be here today to talk a little bit about how we currently approach people with Alzheimer's disease in a clinical setting. I'm going to start by talking a little bit about the historical context, and then how our practice is evolving with lecanemab, and then a little bit about where things may go in the future. So this is not true, but I wanted to put it up because I still hear this occasionally from patients and families, this idea that you can only make a definite diagnosis of Alzheimer's disease after someone passes away and you can take a look at their brain under a microscope. And this comes from criteria that were published in 1984, which is the same year our ADRC started. And it did, with the tools that were available at that point, to make a definite diagnosis did require neuropathology. And so what instead people did clinically was make a diagnosis of probable Alzheimer's disease. And that diagnosis implied that someone had dementia and that it affected memory in particular, as well as other parts of the brain, and that there was no other obvious cause that could explain it. Now, dementia and Alzheimer's disease are not synonyms. So dementia really refers to the significance of the memory problem. And there's a spectrum. There's some age-related changes that everybody gets. Things like a little bit more of that, you've got a word on the tip of your tongue that you can't get out, and walking into a room and forgetting what you went in there to get. And then there's something we call mild cognitive impairment, or MCI, and that is a memory problem that's significant enough that when we do memory testing in a controlled setting, neuropsychological testing, that your scores are really lower than we would expect based off of your age and your level of education, but that you're still handling your everyday activities for yourself. And then if the memory problem progresses to the point where it is affecting things like paying bills on time or remembering to take your medications, then we call that dementia. And it's not doesn't imply a particular cause. It just means, again, that it's a memory problem that's significant enough it affects your ability to live fully independently. And we sometimes talk about the stage of dementia, and I wanted to show this scale. Don't try and read all the tiny little print, but this is a scale that we use in research called the Clinical Dementia Rating Scale. And there's 6 categories, and memory, orientation, which is like knowing the date and where you are, problem solving, and then your ability to do things at home, chores and things like that, and your ability to do things in the community, and your ability to, take a shower and get dressed by yourself. And we rate each of these from 0 to 3. And so then we can add them all up and get a score that's out of 18. And so the clinical trials that Dr. Schneider will talk about for lecanemab, the average score was a 3 out of 18. And it's important because when we think about what is a clinically meaningful effect or not of the medication, the difference between the treatment group and the control group was about half a point on this scale. So that's from moving from the 0.5 to 1 in any one of these categories. So just wanted to give you a little context. Now, if you do notice a memory problem, what do we recommend clinically? And it's always a good idea to bring it up at least to your primary care doctor. We usually recommend that you bring a family member with you if possible, because sometimes people with a memory problem will forget how much they forget. So it's nice to have another person who knows you well who can speak to that. And your doctor will probably ask, what kind of symptoms do you notice? What situations do you see a memory problem? And then again, how much does it affect your everyday activities? Because that's what really separates dementia from a milder memory problem. They'll probably do a short memory test and maybe some blood tests for your thyroid and vitamin B12, things like that can affect memory. And then most of the time, people will end up having a brain scan, an MRI if they can do it, if not a head CT. Now, it's important to understand we can't see the Alzheimer brain changes on an MRI. You can see some of the downstream effects, like the hemorrhages that Dr. Ringman showed, or some of the brain shrinks over time, but we can't see the amyloid protein or the tau tangles. We can't see that on an MRI scan. And so what we have been doing is still kind of like these old criteria, making a diagnosis of Alzheimer's disease based on a memory problem that where someone, it's kind of a particular type of memory problem where people repeat themselves a lot in conversation, have trouble making new memories going forward. There's no other clear cause on either the MRI or the blood test, no stroke or tumor that you didn't know about. And this clinical diagnosis is actually correct most of the time because Alzheimer's disease is so common. And that's been good enough because most of the things that we've been able to recommend for a long time have not been specific to Alzheimer's disease compared to other causes of dementia. Those are things like eating a healthy diet, Mediterranean style diet maybe, and staying physically active, staying engaged in your community, keeping your brain active. And then we've had some medicines to prescribe that help memory, but they're all what are called symptomatic medicines. They replace a brain chemical that's low in Alzheimer's disease. They don't actually fix the amyloid, the plaques and the tangles that we can see in the brain. They just, I tell people it's kind of like if you injure your elbow, you can take a Tylenol and it'll help it feel better, but it's not actually helping the injury to heal any faster. And that's kind of what these medicines do. They're not disease modifying. They just help with memory a little bit. They'll give you a little bit of a boost. And then other common things, just making sure people with memory problems in their families have the support they need. It's pretty common to have some either change, things like depression or anxiety, frustration can come along with dementia. So treating those if they emerge, and then just trying to avoid things that can make it worse. So those are some medications can worsen memory problems, trying not to fall and hit your head, things like that. But this is pretty much what clinical care has been for a long time. Now, this is changing because this new medication that Dr. Schneider is going to talk about, the lecanemab, does require proving that Alzheimer's disease is present before we administer it. And so for that, we need something called biomarkers. So a biomarker is something that can help us detect a disease in someone, in a living person, as opposed to waiting for after someone passes away, proving if Alzheimer's disease is there or not while someone is with us. And so there's a few categories of biomarkers that we can use to diagnose Alzheimer's disease. So there's two major proteins in Alzheimer's, the amyloid, which forms the plaques, and the tau, which forms the tangles in the brain. And we can measure both of those in the spinal fluid. And then there's also, Dr. Ringman showed PET scans. So there are special PET scans both for amyloid and for tau. And those are they're FDA approved. They haven't been clinically available until just now because they haven't been reimbursed outside of a research setting, but we are now all of a sudden able to order amyloid PET if in the clinic if needed. And then there's blood tests that are available, and the blood tests are kind of more of a screening test than a diagnostic test, but those are, gradually becoming more widely used both in research and, kind of starting to make it into clinical care a little bit. And I just wanted to point out that the biomarkers we have are gradually getting better. So, we've moved from after people pass away, looking at, a post-mortem, to spinal fluid, which is it's not a huge procedure, but it's a little invasive, to being able to do brain scans, PET scans to look for the protein. And then again, blood is hopefully kind of starting to come online. So gradually getting easier to diagnose, more support. And the way we've been able to move forward on this continuum is through research. So when someone comes to see me for a memory problem in clinic, we're still doing, hearing about their symptoms and whether they can handle their everyday activities for themselves. I always do some memory testing, and we still do blood tests and an MRI scan. But the big thing that's changed over recently is that now if we're thinking about new treatments like lecanemab, then we actually will want to prove that Alzheimer's disease is there. And so at USC, we're doing PET scans for everybody to see if they might be eligible for the treatment. And the other thing that's changing, the risk of side effects from these medications depends on what version of the ApoE gene you have. And so we've started doing clinical genetic testing much more than we used to determine if we're thinking about starting one of these medications, if we're thinking about starting lecanemab, what is the risk of side effects? And where we're hoping to go, I think, as a field, we know that the changes in the brain, the amyloid in particular, starts to build up years before people develop memory symptoms. And so probably with these blood tests, as we hope they get better, may be able to start identifying people who are at higher risk than average of developing Alzheimer's because of their genetic results, and then move towards screening people with the blood test, the same way your doctor screens you for cholesterol. So that's probably where things are going in the future. And just wanted to emphasize before I end that the way we've been able to move along this pathway to easier diagnostic tests has been through our research participants. So a lot of people on this call are in a study that we ask you to do both an MRI scan and also to let us do a sample of spinal fluid through a lumbar puncture. And through this being able to compare the two, we've been able to validate biomarkers in the spinal fluid for the health of the blood-brain barrier, which we think may contribute to Alzheimer's changes. And now we're starting to be able to detect it in the blood as well. And so this is it's our research participants are the ones who let us move on this continuum from from more involved or invasive procedures to quicker and easier diagnostic tests. So with that, I just wanted to say thank you. Our research coordinator team, who are not here today, I just wanted to let you know they all have new phone numbers. So hopefully that'll get circulated in these slides. And then to all of our, just wanted to say thank you to all of our research participants who, again, are the ones that are helping us bring tools from research into clinical care. Thank you.
So John can maybe come on. I don't see too many questions and we are a little bit behind, but there was one that came in earlier about PET scans, the amyloid PET scan. So this could be to either of you, John or Liz. If at age 73, I don't have any plaques on PET scans, an amyloid PET scan, can this come back later?
Almost certainly it can, but it's also a good news that you don't have it, because as was pointed out by Dr. Yassine, that the amyloid starts depositing 15 years before people have overt dementia. So if you don't have it now, that's good news, but all of it depends on how long one lives, I guess.
Another question could have gone to Dr. Yassine, but here we are. How does obesity affect Alzheimer's disease, or what role does obesity play?
Right. I think Hussein answered that.
So it's really vascular risk factors, and obesity is associated with hypertension, diabetes, is associated with insulin resistance, it's associated with high cholesterol, and all of these affect the brain. It really gets complicated when we talk about obesity in midlife between 40 and 60, and obesity later in life after 70 years of age, because it seems like there's association studies that obesity later in life might be protective. So we want to deal with obesity mostly in midlife and have alternative recommendations later in life.
Okay, there's still some other questions about ApoE4. Is there an average onset age if you have 0, 1, or 2 copies of ApoE4? I answered it also online. So usually, as Lon says, Lon is here, 1 copy of E4 brings the diagnosis 5 years before, 2 copies 10 years before. But of course, you've got E4 carriers who don't get the disease and non-carriers who get the disease.
And one thing that should be mentioned is most of what we know about ApoE risk has been studied in Caucasians of European descent. So it's clear that the degree to which ApoE drives Alzheimer's risk is also dependent on the rest of your genome. So, for example, people of Japanese origin, ApoE4 has a bigger effect, whereas people of African or Native American origin, ApoE4 seems to have a less of an effect. So there's a lot of variability for that reason and others around the age of onset. So there could be there's a mean age, but with lots of variability.
Well, there's a question here. What's the difference between amyloid and tau and how they contribute to Alzheimer's symptoms?
Right. That's a tricky question. That as far as amyloid and tau, how we can see them on scans, that it is well known that there are people that have positive amyloid scans that have no symptoms. So the correlation between amyloid pathology as visible on scans and people's clinical status is indirect and not strong. Tau, on the other hand, really is tau pathology. The neurofibrillary tangle pathology that I showed really is a good correlate of how healthy that bit of tissue is. So you can, by looking at someone's tau PET scan, you can predict the degree of their symptoms. There's a good correlation. If you have tau pathology in the medial temporal lobe, they're likely to have a memory problem. If they have it in other parts of the brain, you can predict what problems they'll have depending on what that part of the brain, what function that part of the brain subserves.
Thank you. Dr. Joe, here's someone I've resisted the CSF test as a research participant, but is it too late to consider donating a sample now?
No, we would love to have you consider that. And I actually know which study you're participating in, so I'll let the research coordinator know. And when you're next due to come in for your research visits, we'll ask you again how you're feeling about it, and we can go over the lumbar puncture procedure in a little bit more detail. I always tell people it's about, for most people, it's kind of on par with going to the dentist. So it's not, it's usually not quite as bad as people are expecting. Most people don't find it a big deal, but we can talk about it in more detail.
If I'm currently part of the study, will I ever have access to the results of my spinal fluid and PET scan?
That's another great question. So the spinal fluid results through the study, we analyze them in a research lab that is not a clinically approved lab. So we are not in a position right now to share the spinal fluid results with you. We also kind of process it in batches and not in an ongoing way to give you results right away. The PET scans, we would like to be able to share the results with our participants, and we're kind of working internally to figure out how to do that. So I hope over the next year we may be able to share your results with you. We're not quite there today.
Helena, let me add to that a bit for the general question. Can you find out your result, if you participate in a study, can you find out results of your biomarker tests, of your CSF tests, of your plasma tests, of your PET scans? And the simple answer is it depends on the study. Because of what Dr. Joe just said, some of the tests that are done are purely research. Other tests are tests that are clinically available and being used for research. So it just depends on which study, on the study that you might be in, and you should ask about it.
And
So I'd like to address this question, if I may, Helena.
yes, go
Question is it possible that drugs clearing amyloid might have less bad side effects through CAA if they are given to people when they're in the younger, not yet symptomatic phase, so that there is less potential weakening of the blood vessels because there is less amyloid being removed? We think so. So yes, so that's the anti-amyloid antibodies are proven in people with mild to mild Alzheimer's disease, but there is an effort to go even earlier for this reason and others, that they might be more effective, but they also might have less problems, cause less side effects, yeah. So one of the values of studying folks who have these young onset forms of Alzheimer's that I study is that you can really predict what stage of the illness they're at even before they have symptoms. So that's anti-amyloid antibodies are being studied very early in the course of those folks.
I think the question about the timing of giving these anti-amyloid drugs will be addressed by Dr. Schneider as well. At the end of his talk, he'll talk about future directions, which is to go earlier and earlier before symptoms. And so, thank you, John. There's a note there from a UK study by Bart de Strooper, and
Right.
maybe we'll come back to that after you have a chance to go on to that
read
link. And I'll move on now to thank you, Dr. Joe and Ringman. Lon, gives me great pleasure to introduce Dr. Lon Schneider. He and I have been together since our USC ADRC was founded in 1984, and he really is my guru for what's the latest in clinical trials for Alzheimer's. Go ahead, Lon.
Yeah.
You can maybe show full screen. Perfect.
Do I have full screen up now?
Now you do. You do.
Okay. Excellent. Yeah, I really have full screen here.
I know that's the thing. When you're in full screen, you are in a cave.
All
But
right.
we can see you as well, so it's perfect, and we can hear you fine.
Okay, well, I wish you can all be in my office now to just see how huge this screen is in front of me. But anyway, thank you very much for the introduction, and I'm delighted to be here again and at the Batey Appreciation Day, and to talk now today uh, about lecanemab. Lecanemab is the generic name for the antibody. Leqembi is the brand name. And so I will primarily discuss and try to inform you about the clinical study on which Leqembi was approved for treatment of people with Alzheimer's disease. And I'll talk a bit about the methods, the outcomes, the main adverse events, and then a little bit about what's next. As Dr. Ringman emphasized in discussing the amyloid hypothesis, the antibodies like Leqembi were developed to attack the amyloid plaques and to effectively reduce amyloid by binding to the plaques, and then that complex is then phagocytosed or eaten up by other cells in the brain called microglia, that will envelop the complex and essentially destroy it. In the process of doing that, these microglial cells also seem to reduce the neurofibrillar, the tangles that represent toxicity for neurons. So the act of reducing amyloid with antibodies has a number of advantages. What Leqembi is so all antibodies are, not all antibodies, most antibodies are developed from IgG, from gamma globulin, which you've probably heard of as being used for transfusions, being used to treat various infectious disease and cancer and immunological disease. And so what Leqembi is an adaptation of gamma globulin. The gamma globulin is made in mice by raising it against amyloid that is injected into the mice. And so we create this antibody, which we then humanize and make into a drug. There was a phase 2 study of lecanemab about 10 years ago that gave essentially the permission, the evidence to conduct the phase 3 trial that we rely on and that I'll discuss with you in a moment. But in January, well after the phase 3 trial results were known, in January, FDA gave Leqembi a restricted accelerated approval that could allow it to be used medically and clinically. And then just recently in July, lecanemab got full approval, regular approval for a medication. So I'm going to shift and now give you some data. And by telling you about the study, I'm also telling you a bit about how we will be and how we do use the medication clinically. Dr. Chui will also follow up on that. As Dr. Joe described, we, in terms of diagnosis, people who are eligible for Leqembi have mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's dementia. What that means is that on the one hand, their cognitive impairment is not that severe. Their mini mental state scores are 22 or above approximately, and their ability to remember a story is largely just so towards the edge of being abnormal to being abnormal and impaired. But what's most important is that they had a positive amyloid PET scan. So that combination of MCI due to AD, mild AD, and a positive amyloid PET scan and the cognitive impairment was eligibility for the phase 3 trial. In the phase 3 trial, and the way Leqembi will generally be used, is that patients were randomized to 10 milligrams per kilogram, a customized dose, given by intravenous infusion every 2 weeks over the course of 18 months. In the trial, they were randomized to placebo as well. So one group got placebo every 2 weeks infused for 18 months. And the randomization was controlled to make sure that we could tell whether people with ApoE4 with ApoE4 carriers were benefiting, and whether the effect of lecanemab was altered by the use of donepezil. At the same time, in these trials, because of the concern for edema and hemorrhage, as Dr. Ringman discussed, very frequent MRIs were done to look for evidence of edema and hemorrhage in case we needed to take certain steps. The primary outcome in these studies was the CDR. Dr. Joe showed you that graphic, that grid of the CDR, the Clinical Dementia Rating Scale assessment. What's really important in these studies is that the secondary outcome was actually not a clinical rating, such as a cognitive rating like the ADAS-Cog, but was the PET scan itself. Was the test to see whether Leqembi would reduce amyloid in brain. And that's new in the FDA to use a biomarker as an outcome. Cutting to the chase, this is what the people who were tested looked like. Mainly, they were about 71 years of age. They were outpatients. Half were female. 73% of them were of European descent. And then approximately 80% had 60 to 80%, 70 to 80% had mild cognitive impairment due to Alzheimer's disease, with the rest having mild dementia. Also, nearly 70% were ApoE4 carriers. I wanted to point out that in this clinical trial, over half of the patients had hypertension, 15% had diabetes, and 16% had obesity. These are risk factors for Alzheimer's disease, as Dr. Yassine discussed. And it is in part a reminder that perhaps more emphasis should be placed early on in reducing risk. Here is the basic outcome of the trial. It should be no surprise. There was a statistically significant difference on the CDR sum of boxes, and that difference was 0.45 points. And that was enough for FDA to approve the drug. It is not as large an effect as we would like, as Dr. Ringman discussed. It's actually a pretty small effect and has engendered some controversy and concern over whether this effect is large enough to make a difference. And we'll discuss that. We'll discuss that later on. But what you can clearly see is that these anti-amyloid drugs markedly work on amyloid and reduce plaque on amyloid PET scan. There is no question about it that these medications markedly reduce plaque. Dr. Sheikh-Bahaei will talk a little bit more about that later. And moreover, the biological activity here is really fairly impressive. Dr. Ringman talked about the biological changes, and Dr. Joe talked about the biological changes that occur with Alzheimer's disease. Here, this set of graphics is showing not only is amyloid plaque reduced, but tau and phospho-tau associated with neurodegeneration and neuronal loss, and some of it Alzheimer's specific, is markedly reduced, and as well as other biomarkers, as well as biomarkers that are involved with the microglia that I spoke about, that helps to clear amyloid. So this is quite potent on a biological level, even as clinically it's a bit less potent. Adverse events. These are important, and overall, these are important, but overall and in a nutshell, there are three main adverse events to infusion to lecanemab. One is infusion reactions. The other is the ARIA-E, or the brain edema and swelling. And the third are the microhemorrhages, and we'll talk about it, and Dr. Sheikh-Bahaei will talk about it later in greater detail. But again, kind of to reduce some of this, in a nutshell, the total amount of ARIA, of the amyloid-related imaging abnormalities that reach a serious status that might require extensive intervention, is about 1%. And in I should have said is one, and also infusion reactions total, when you add it up, is about 1.5% or so. Beyond that, adverse events are, from a technical point of view, mild to moderate. Also, in a nutshell, the amount of edema or hemorrhage or microhemorrhages is about 21%. But the importance there is that of that 21%, over 95% of it is reversible and does reverse on its own. A photo of someone receiving an infusion, to point out here on this graphic that about 26% of people will have an infusion reaction, and most of that, 96% of that, is mild to moderate, and 75% occurs only once. The rest occurs pretty much only twice. And then with the edema, Dr. Ringman showed you some examples of the edema. The key takeaway, the key thing you want to keep in mind, is that 91% of it is mild to moderate. 80%, 78% is totally asymptomatic, and that most of it is occurring, 71 to 92% is occurring in the first 6 months before it resolves. The point that we can discuss, that Dr. Chui might discuss later, is that what we learn is that, for the most part, edema is occurring in the ApoE4 carriers who are homozygote, who have 2 copies of ApoE4, and to a lesser extent in the ApoE4 in the carriers that only have 1 copy of ApoE4. Hemorrhage is similar. About 17% of people will develop these microhemorrhages. They are stable in most cases when they do occur. Sometimes we stop medication, other times we can continue medication. But what's also important is that when you're old, you get microhemorrhages spontaneously. And about 9% of the people on placebo who were fairly healthy over 18 months developed the same microhemorrhages. So this is what we know about treatment with lecanemab. We know that it is effective, that it is measurably effective on clinical ratings. We know that it has a strong effect on biomarkers, and we have a good handle on the adverse events, which are infusion reactions, edema, and microhemorrhages. Patients need to receive counseling about the edema, and especially if you're an ApoE for homozygote carrier. There are numerous challenges, as you can see, to using lecanemab, in that our procedures tend to be complicated, or at least time intensive in terms of assessment and treatment. And what we'll get into later are that there are barriers to treatment that are quite considerable. It requires a good amount of commitment, and also our ability to lower those barriers. And then the benefit considerations are the amount of plaque reduction, clinical benefit, and the potential that using lecanemab now might help in the future. Would I qualify? How would I qualify for lecanemab? Dr. Chui will pick this up towards the end of these presentations. But these are some of the factors that you can read faster than I can list them off. In the end, the decision becomes quite an individualized decision. What's next, though, for amyloid A beta antibodies is that in December we would expect the approval of another amyloid antibody, donanemab. And if it is approved, we'll be able to tell you about how it is similar to lecanemab and how the two may differ. The other main aspect for the future of anti-amyloid antibodies is what we were discussing earlier, and that is, it seems as though they should work much earlier in the course of the illness, when there's relatively little amyloid around blood vessels, and when then the antibody could be more potent, and at that time perhaps have a greater effect on the future development of the illness. So to that end, there are two studies in what we call preclinical Alzheimer's disease. The one we do at USC is with lecanemab. It's called the AHEAD 3-45 trial. And basically, this is recognizing people who are cognitively normal with a positive amyloid PET scan as having preclinical AD and being potentially and might potentially benefit from lecanemab being used for several years. Yair Avila and Carlotta Conant are managing that study. So I ran over a bit in my planned time, but I wanted to thank you for listening, and then also encourage you to consider one of our many either observational studies that Dr. Joe and Dr. Yassine are doing, that we're doing, or intervention studies. So thanks so much.
Thank you so much, Lon. I know we've been at this a while, and we just have some time now for questions. And with Dr. Schneider, we will take a break right after the questions for 5 minutes. But first question, Lon, is there any hope that lecanemab can be given other than IV, other than intravenously?
Well, yeah, great question. There are ongoing studies of a subcutaneous version of lecanemab. These studies are sponsored by the pharmaceutical company, and they're made to look to see whether there's an equivalent pharmacokinetics between giving the medication subcutaneously versus intravenously.
So could you clarify, is the black box warning only for ApoE homozygotes, those people carrying 2 copies of ApoE4?
So black box warnings are officially called public health advisories, and what they tell the public, and what they tell physicians is bring up these issues with the prospective patient. And there are two aspects of the black box warning. One is the recommendation that people who are ApoE4 homozygotes have some additional counseling about the level of their risks and the pros and cons. The other is for us to be able to discuss, as we have in a few of these presentations, about the edema, that you be generally informed about the brain swelling and the hemorrhage. That's what the black box warning means.
Thank you. Is there any benefit to receiving lecanemab for those who have moderate Alzheimer's disease?
That have moderate. So we have no idea. We felt, or collectively the field felt, as these medications were being developed, that very early on, patients with mild to moderate Alzheimer's disease were enrolled in a vaccine trial, in a trial of an earlier antibody called bapineuzumab. And it seemed as though those people who were more moderate did not benefit clinically at all, not even though the whole study that people didn't benefit, and had some somewhat more adverse events, probably because they had more perivascular amyloid. So then there was a movement to treat more mild patients. But it's still an open question whether moderately impaired people with dementia could benefit from this. But we're not in a position to test that or to provide that.
As far as the adverse effects, are there dosage or medication changes for those who are on blood thinners?
So it depends on the blood thinner, and it depends on why a person is taking it. They're actually not contraindicated. Antiplatelet drugs are not contraindicated. Anticoagulants that interfere with the blood clotting cascade, the set of proteins that are involved in blood clotting, also are not totally contraindicated. I think it's best here to say it depends, and there's also a value that to the evaluation, a consideration to the evaluation. Somebody who has a good amount of strokes and maybe on an anticoagulant probably should not receive Leqembi or other antibodies. So I could wish I can't really give the answer to the question about anticoagulants is individualized, possibly.
Okay. I think we should take a few. I have a few more questions here, but I think we should take a break. There's a couple questions here about people in other studies, like in HMRI, the Huntington Medical Research Institute, and whether those are the same as USC. They are separate, but we do have people who are in both studies. There's a note here about cousins in Minnesota that have ApoE4. Can they somehow participate in the studies we have at USC, or is there something in Minnesota that they could join? We do have ADRC in
there are certainly many studies in Minnesota, and especially in the Rochester, Minnesota, and Minneapolis, St. Paul area. The density of available studies is as good there as it is here. We have numbers of observational studies, as Dr. Joe had exampled, that people can join and maybe only visit us once a month, once every 3 months, once every 6 months. So it's possible.
Okay, and then here's some maybe two questions for you, Dr. Joe. I'm diagnosed with PPA, primary progressive aphasia. That's a type of Alzheimer's disease, or as we know, could be frontotemporal dementia too. Would I benefit from the new treatments available?
It's a great question. And the new treatments weren't specifically studied in people with PPA. Sometimes it's due to Alzheimer's disease and sometimes due to other causes. And so maybe if it's due to Alzheimer's, we can think it might help, but it's not, no, there hasn't been a specific trial. So I think that you should probably talk with your neurologist about whether that's a good fit for you or not.
Thank you. Then Liz, to you and to Lon, just I think a little more clarification about in the Clarity study of lecanemab versus placebo. What again did CDR-SB measure?
So that is it's the CDR sum of boxes, the clinical dementia rating scale, the sum of boxes. So that was, I showed a chart that was 6 rows by a few columns, and so there's 6 categories, and people get a score from 0 to 3 in each of the 6 categories, and then you add them all up. And that is a tool that lets us know how people are doing overall in terms of their memory, their ability to take care of their everyday activities. And so that's what they used as the primary outcome for this trial.
Yeah, Dr. Schneider. So the mean difference between the treatment group and the placebo group in the Clarity study was 0.5 on the CDR sum of the boxes. So what does that mean?
Oh, great question. It was actually, for those counting, 0.45. Close enough to 5. What does that mean? So unfortunately, this has been controversial. And this is where we talk about the clinical effects, although they're measurable and advantageous for the antibody, they are much smaller than the biological effects, and they're smaller than what we had hoped. And so some people say, well, this is a first step. This is important. This also means that if it's a very small number, that on average means very little in terms of one patient, there are still other patients who have benefited greatly in the study. And therefore, this is clinically meaningful. There are others that say, no, that 0.45 difference or the 0.6 difference with donanemab is just not big enough to make a difference over the course of 1.5 years of the study. Then there are others on the other side who say, well, that's just 1.5 years. And part of the hope is that if we do take it for 1.5 years, and if our plaques are reduced, that will mean that going out into the future, the course of my illness will be changed somewhat. So this is unknown. And this is why there's some discussion and argument about whether that 0.45 difference is meaningful or not. You can make the argument that it is, and then others will say, well, it's just not big enough.
Dr. Nasim Sheikh-Bahaei, who is an MD, PhD. She's assistant professor of radiology. She's a neuroradiologist, and her expertise is in amyloid and tau PET scans, as well as MRI scans. And she is our expert here in detecting ARIA. And behind the scenes of the neurologist, who you'll see in clinic in Leqembi treatment, it's Dr. Sheikh-Bahai's team of neuroradiologists behind the scenes that are looking very carefully for ARIA. Welcome, Nasim.
Thank you so very much, Dr. Chui, for the introduction. It's a pleasure to be here today. And I'm going to start. As you kindly mentioned, I'm going to talk mainly about the imaging component for the selection of the cases for anti-amyloid treatment. I'm going to talk about what sort of pre-treatment imaging every candidate should have, who will be excluded from the study based on those findings on the imaging, and what are the effects of the treatment on imaging. You've all heard about the amyloid-related imaging abnormalities on the prior presentations, or ARIA. We're going to talk about how we categorize these ARIA changes on imaging and how it will change the management. So selection criteria for treatment, we have a groups of inclusion and exclusion criteria. Inclusion criteria, you heard already from Dr. Joe's presentations, many of them are based on the clinical findings, but also we have to confirm the presence of the amyloid on PET or CSF before even considering the treatment. And there are groups of exclusion criteria, which many of them are based on imaging, particularly MRI findings. If a patient has any of those, then they won't be suitable to receive the treatment. Based on that, every single candidate, before even considered for the treatment, they should have at least two sets of imaging. One is the positron imaging tomography. Many of you have heard of it, called PET. And the second one is just mainly, as we said, is to confirm that the patient has the amyloid in their brain. And the next one is MRI, is to look at any other causes that can potentially reduce the cognition, and also to look at for any of those exclusion criteria, which may increase the risk of having side effect after the treatment. What is PET and what does it do? So we have different kinds of PET, but particularly for in this treatment, we use the PET, which is specifically for amyloid. It means that the patients will get the injection, which we call it a tracer. It's labeled, but a radioisotope for amyloid. And then they go into their scanner and they have a short imaging time. The tracer is actually attached to the amyloid plaques in the brain, and it just lights up as area that you can see in this imaging as red, and then we can confirm that the patient has amyloid in their brain. The next step is just to do an MRI scan, as I mentioned before, to exclude any other causes of potentially cognitive impairment or to look at exclusion criteria. There are different exclusion criteria based on the imaging. The first one that we look for is that the area of a small area of potentially asymptomatic hemorrhage in the brain, what we call it microhemorrhage. And we will find this area of like a black dot on the brain. Patient may have them, they may not have any symptoms, but if they have more than 4 of them in their brain, then they will be excluded from the treatment. The second kind of exclusion criterion is based on the evidence of prior hemorrhage in the lining over the brain. So there's lining over the brain. If we see this dark line, it tells us that they have hemorrhage in the lining of the brain in the past. And again, if they have more than one area of it, this changes, they will be excluded. The third groups of exclusion criteria is based on the health of the small vessel in the brain. If we see the large area, which is showing the significant area of poor circulation of the brain or damage of the small vessel in the brain, as we can see in the area of that lights up as a white in this image, then they will be excluded from the area. History of previous large bleed into the brain is another exclusion criterion. And then we also need to know the evidence of prior infarcts in the brain. So if somebody have more than 2 small infarcts or 1 big infarct, which is more than 1 centimeter, again, they won't be qualified to receive this treatment. So if somebody has all the clinical assessment and then the amyloid PET, which shows the positivity or the presence of the amyloid, then as I said, we do the MR. And then if MR doesn't show any exclusion criteria, and then based on the decision between the patient, the clinician, patient can be enrolled into the treatment, then they're going to have a certain follow-up MRI on the set points during the course of the treatment. It's going to be 1 MR before the 5th infusion, 1 before the 7th infusion, and 1 before the 14th infusion. However, these are the set point for the people who don't have any symptoms. If patients become symptomatic during the course of the treatment, Anytime during the course of the treatment, they may have additional MRI, particularly in the first few weeks. If there is any evidence or any symptoms, then they can bring they will be bring back to have extra MRI. So what is ARIA? ARIA stands for amyloid-related imaging abnormalities. What causes it? We really don't know. It's not completely understood, but what we know that is it's usually more common in people that have ApoE4 changes. There is a belief that obviously during the clearance of the amyloid, we are going to clear some of the amyloid from the wall of the vessels. And as a result, those vessels may become more leaky. When they become more leaky, then fluid and blood can actually extend to the tissue surrounding the vessels. If the fluid goes out, it can cause what we call it edema or ARIA-E. And if the blood goes out and results in small amount of hemorrhage or bleeding around the tissue, then we call it ARIA-H or area with hemorrhage. What is important is ARIA usually happens early in the course of the treatment. So that's why the first few weeks are the most important time post-treatment for evaluation of the patients, or if they become symptomatic to see their clinicians and to be scanned again. This is just showing a couple of cases with the ARIA-E or area with the edema. It shows area of this white area in the brain. This is area that has edema, or they may have a little bit of edema in the lining of the brain. And ARIA-H are the cases they may have small amount of tiny hemorrhage in the brain. There's like tiny dots, black dots, shows that they have a small hemorrhage, or they might have a little bit of a hemorrhage again in the lining of the brain. What is important that most of the cases with ARIA, they don't have symptoms. So they are mainly asymptomatic, but we will see these changes on their imaging. We categorize the severity of the ARIA depends on the size and the number of these changes. So if the area of the edema is less than 5 centimeters, we consider them as mild, or if they have less than 4 small, these tiny foci of the hemorrhage in the brain. When the edema gets larger, between 5 to 10 centimeters, or if we have between 5 to 9 tiny area of the hemorrhage, they go to moderate, and the severe case are when then the size of the edema is more than 10 centimeters, or we have more than 10 new foci of the hemorrhage or bleed into the brain. I think it's been discussed before, but it's worth to mention it again that most of the cases with ARIA, they don't have any symptoms. So only 3% of the people with the changes on their imaging, they may show any symptoms clinically. And it's usually more common again in people with the homozygous ApoE4. And in terms of the severity, only 1% of the cases will have severe ARIA-E or 3% severe ARIA-H changes. So overall, it's very uncommon, and the symptoms with them it's not often seen. Even in the severe or symptomatic case, which is relatively rare, they usually goes away by itself. Again, a couple of cases that shows ARIA-E in the as categorized as a mild, which you can see is a less than 5 centimeters and just involve one part of the brain. And it's a case with the ARIA-E with the moderate changes, which gets to the slightly larger than 5 centimeters, but doesn't get to the 10. So we categorize it as a moderate ARIA-E changes on the brain. Why it's important to kind of categorize it? Because it's going to change the patient's management. So imagine if somebody comes and have an MR and they had some changes, either ARIA-E or ARIA-H in their brain. If they're completely asymptomatic, so we find the changes on the brain on the MRI, but they don't have any symptoms, and the changes based on our category is mild, then they're going to continue with the treatment. There is no change in the course of the treatment at this stage. However, if they don't have any symptoms, but the changes we see on the MRI are moderate or severe, then we are going to suspend the treatment. If they come with the symptoms during those first few weeks, relative of the severity of the ARIA, even if it's a mild, moderate, or severe, again, if they have symptoms, then the treatment will be suspended. At this point, patient will be reviewed monthly with MRI and with clinical assessment. If the symptoms resolves, the changes on MRI resolves, and patient wishes to continue the treatment, they can resume the treatment. afterwards. There are some certain changes that may result in stopping the treatment altogether if somebody has a large area of the hemorrhage, not those tiny microhemorrhages, but the large area of hemorrhage, or if they have more than 10 of those tiny hemorrhages in the brain, if the ARIA comes back again more than 2 episodes. So these are the kind of some of this criteria that we may decide to stop treatment altogether. Now I'm going to finish my talk just showing you some examples of the cases that they develop ARIA based on the clinical trials that they've done. So this bottom line is just a baseline showing that the decision made on the scan, and the patient developed a very tiny amount of edema in their brain, categorized as mild, asymptomatic. They continue with the treatment. This is somebody has much larger area of the edema, probably categorized as a moderate to severe. Then it's going to be suspended, follow up. If clears, patient asymptomatic, restart. Something again between the mild to moderate gets probably to the moderate category, the same as this one. And again, if there's a moderate to severe, the treatment will be suspended, and then they will be follow up, and then they resume the treatment after clearance of the changes on the brain. Going to finish just showing this one. Again, area is most of the time is asymptomatic, so only 3% may have symptoms. The severity is usually very low, so most of them may have mild or moderate, and then the severe case of area E and area H is 1 or 2% of the cases, and most of the time we don't need to do anything about it. It will resolve by itself. Thank you so very much for your attention. I will be happy to take any question.
So, Nasim, you and I will have a question and answer session together. So I'm just going to move into my talk, which is also on the practical aspects of treatment for with Leqembi. Can everyone see my slides? Yes. Okay, so this medication was called lecanemab, the generic name. And once it got approval by the FDA, full approval in July of this year, then we have the brand name, Leqembi. So lecanemab and Leqembi are the same medication. And I'm going to tell you a little bit about what's available for treatment. I mean, clinical treatment with Leqembi at USC. And so I showed translational research at the beginning in the introduction, talking about bench to bedside and then clinical trials. And you heard from Dr. Schneider about the Clarity phase 3 clinical trial for lecanemab and the frequency of the benefit, the 27%, the 0.5 difference in the CDR, some of the boxes, the benefit to the group receiving treatment compared to the placebo group, but also the possibility of ARIA side effects. And now I'm going to be talking about the clinical practice, the clinical treatment as patients with Leqembi, the brand name at USC. And research will still be ongoing once a medication has gone into the clinical practice world. So what I will cover is just again a quick review of the evaluation and treatment protocol that's approved by the Pharmacy and Therapeutics Committee at the Keck Hospital. It follows the clinical trial design very closely. I will show you the names of the neurologists at Keck who are prescribing Leqembi at this time. Tell you a little bit our process to be sure we're very careful and systematic in reviewing potential patients to receive Leqembi. We are using something called a review board format, similar to what has been done in cancer and has been called tumor board reviews. tell you where infusions are actually being administered, namely at the time being at the health science campus. And then this contact phone number for clinical practice. We've probably shown you a lot of phone numbers today. In your brochure, there's the phone number for research studies. It's 323-442-7600, but I'm showing you here the one contact number for clinical practice, 323-442-5710. This is the same number that Dr. Yassine showed for the dementia prevention clinic. So Leqembi in practice is approved by the FDA for mild cognitive impairment or mild dementia due to Alzheimer's disease. Since Leqembi is a special medication that targets amyloid and has potential side effects, we wouldn't want to expose people to this medication unless they have the target beta amyloid. In research, we use cerebrospinal fluid or PET scans or autopsies to confirm the presence of amyloid plaques. But at USC, our protocol is to confirm it using amyloid PET scans, which are being paid now by Medicare, 80% coverage. We are going to review at our registry board patients to make sure they're not at too high risk. And we will exclude people very similar to as was done in the phase 3 Clarity study. That is ARIA already present. Or a person cannot have an MRI to screen for ARIA because of, say, a pacemaker. Or the person might be on anticoagulation like warfarin or Xarelto or other anticoagulants that might increase the risk of ARIA-H, ARIA with hemorrhage, and other unstable medical or psychiatric conditions. The Clarity study lasted 18 months, and our treatment protocol at USC also lasts 18 months. Each month, every 2 weeks, the person gets an IV infusion of Leqembi. So over 18 months, that means 36 infusions. So this is quite a commitment on the part of the patient and the supporting partner. Very important that there be someone who is also helping support. At the very beginning, we get the amyloid PET scan to confirm there is amyloid in the brain, and we get an ApoE genotype to see if there's 1 or 2 copies of ApoE4, which would increase the risk of getting ARIA. We get the MRI 1 year before we start Leqembi, and then before the 10th week and the 14th week and the 28th weeks. And these MRIs will be read by Dr. Sheikh-Bahai's team. If most of the time what we see in the MRI will be asymptomatic, but we, as Dr. Sheikh-Bahaei says, we start to watch our patients very closely. If the ARIA is mild, we can continue, but we need to pay close attention to the MRI. If the ARIA is moderate or severe, then we would stop Leqembi until things improve, or in some cases stop entirely. At the end of the 18 weeks, we would repeat the amyloid PET scan, and we would expect that the amyloid would be completely clear. We would hope that people's symptoms would have been slowed, and we're not exactly sure what to do after these 18 months. We're just in new historical territory. The symptoms are relatively infrequent. Only 3% of people get ARIA-E that is symptomatic, and only about 1.5% get symptomatic ARIA-H. But we can see ARIA much more frequently, up to 15% on the MRI. And most of the time, it's going to be asymptomatic. The symptoms, when they come, are frequently headaches, confusion and dizziness, changes in mood or behavior, nausea, gait disturbance, blurred vision, and very uncommonly, I've never seen it, but very uncommonly, a seizure. The prescribing neurologists at USC at this time include people you've met today, and some you might know if you're also patients. There's myself, Dr. Joe, Dr. Collins Liu, Dr. Ringman, Dr. Arus Barpadian Moran. I see I've misspelled Moran, and Dr. Catherine Wong. All of us practice at the Healthcare Consultation Center at Health Science Campus. Dr. Wong practices also at Beverly Hills. If you'd like to make an appointment because you're interested in Leqembi, then you can call 323-442-5710. Then there's a telephone tree. You dial 1 and then dial 4 to reach the memory coordinator, Maria Hernandez. And again, this is the same number to call if you're interested in Dr. Yassine's dementia prevention clinic. If the prescribing neurology list that I showed you before feels you're a good potential candidate for Leqembi, then that neurologist would refer for review board systematic assessment for medical clearance. The board will review, and the board is just the same group of neurologists that I showed you, but we do this together. We review inclusion, exclusion criteria, and once a patient is medically cleared, the neurologist will initiate internal orders for financial consultation, infusion appointments, follow-up MRI appointments, and follow-up clinic visits. And we have organized this so that these are all order sets. This is one of the challenging things of administrating Leqembi in practice, is that there needs to be close coordination between the treating neurologist, the infusion center, the neuroradiologist, and the follow-up clinic visits. At the present time, we are giving these infusions in HC3. HC is a healthcare consultation center. This is too long, so we just have abbreviated HC3. We see patients here in HC2. We also see our research participants in the ADRC at HC2. The PET scans are done in HC1, so they're all together, and you can park underneath HC2, here parking, or in the parking structure for the Keck Hospital parking lot 6. Blood drawing for ApoE genotype is also done in the same building as the infusion center. This is the phlebotomy center. It's in HC3. The key contacts are that number 323-442-5710. This is again for patients, for clinical practice. This is not for research. The memory clinic coordinator is Maria Hernandez. The nurse coordinator is Kimberly Emerson. We have USC Care neurologists on call 24/7. The group of neurologists on call is much broader and greater than the prescribing neurologist, but the group on call knows how to reach the prescribing Leqembi neurologists. And here's some other numbers for the infusion center, MRI scheduling, and PET scheduling. We have a financial consultant so that you would know exactly what you might be responsible for out-of-pocket expenses. Medicare has agreed to cover 80% of appropriate services at allowable costs. That's you have to kind of unpack that. So Medicare has the ability to, to just establish what they would consider allowable costs. We were talking about costs for the medication itself, Leqembi, which is, I think, $28,000 per year. But we're also talking about the cost of the PET scan, and I'm not exactly sure what the allowable cost will be for that amyloid PET scan. And also, Medicare will pay for 80% of the surveillance MRIs that are necessary. Okay, so that still leaves 20% of costs to consider. Many people have supplemental insurance, but we're not sure exactly who those supplemental insurances are now. So the financial consultant will handle this on an individual basis. The pharmaceutical company that makes Leqembi, Eisai, will also provide financial support services that can cover some of the remaining 20% costs. So there is a website where you can see if you qualify, if the 20% is not already covered by your own supplemental insurance. And so I want to end my presentation by stepping back and thinking, how did we get here to the first disease-modifying treatment? It's exciting. It's a new era. We finally can do something. It's not a cure. You can see that the 27% is modest. This is not simple. It's still IV. There are some ARIA side effects that we have to be vigilant for. But I put up here the clinical trials at USC that have been really organized by the principal investigator, Dr. Schneider, Lon Schneider, who you heard from today. Solanezumab, the A4 study for people that were amyloid PET positive, and for those that turned out they were amyloid PET negative, well, that's good news. There was the LEARN study. The lecanemab study, for the clarity you've heard about today, but there's an ongoing lecanemab study for people who are not symptomatic. Clarity was for people with mild cognitive impairment or mild dementia due to Alzheimer's. AHEAD is for people that have amyloid PET scans that are positive but are not symptomatic. So we have that ongoing now. Dr. Schneider is also participating in the donanemab Trailblazer 3 study, and for people with early onset, like in the 30s or 40s, that carry an autosomal dominant mutation. This is Dr. Ringman's specialty. Dr. Schneider is participating in the TAL monoclonal antibody study. So to our dear participants and study partners, we wouldn't be here today with an FDA and a CMS Medicare approved DMT, disease-modifying treatment, without your determination and dedication. Hooray, we should celebrate this, and thank you. So, John, could you leave any questions to Dr. Sheikh-Bahaei or myself?
Most of the questions are about wanting the presentation recorded and the slides.
Yeah, so I've been answering a little bit that, I've gotten, for the past 6 months, hold the date, September 30th, Batey Research Participant Appreciation Day. Then another one, it's a month away now. It's only 2 weeks away now. So the person who's been sending out and preparing, it's been a team. It's been Alice Gunderson and Tara Rose. Maybe they can come on, and they will be communicating after this conference about how you can get a copy of the presentations, either as a PowerPoint, PDF, or if you want access to the recordings, because we are recorded this morning.
We will be sending out hard copies of the questions and answers, and they'll be in your mail as well as on the website, on the USC Memory website. So we really appreciate all the wonderful questions, the presenters, but I think the questions and answers people have really inputted. So yes, you will be receiving those.
I just wanted to add that the trial for autosomal dominant Alzheimer's, the Diane-TU that was mentioned, it is a study of an anti-tau antibody, but at some point, every participant in the study does receive Leqembi. So it's the idea is to see if, assuming Leqembi is going to have some effect, we can study that, but also can this anti-tau antibody have an additional benefit over that? So another question, the only unanswered question is, do iPSCs have the potential to repair the brain cells and or restore the connections between the neurons? So my short answer to that is not tomorrow, not this week, but that is an area of research and is a potential. People are studying that. It's not easy because it's not like a liver where you just got to stick the cells in there and get blood flowing through them. They have to hook up right. So that's an ongoing challenge in that field. But that and other aspects of stem cell type research is certainly being done in the laboratories at USC. But the recurrent questions of this one came up twice, I guess, is my understanding is that for the foreseeable future, clinicians at USC will only be infusing at USC. Doing it outside, I think, is more complicated. To the extent to which other institutions will be doing this, potentially at closer locations to where people live, I think is an unfolding answer.
So if I can add to that, a reason for this also is to make sure we have the fail-safe mechanism in place so that somebody doesn't accidentally continue to receive infusions when we see on an MRI that they have some edema and they need to temporarily stop the infusion. Here at USC, we have complete control over that, and otherwise we would not.
Right. If any of you are out there are patients of mine, you know how frustrated I get when I can't get outside records. And we need to see those scans, right? There can be no wiggle room there, and we need to see them in a timely fashion. They have to be done in the right way, etc.
Yeah, maybe that's a good point. Dr. Sheikh-Bahaei, is there anything special about the sequences that your team offers as opposed to going for an MRI somewhere else?
Exactly. So that the sequences we use are very specific for this, both for selection of the cases and also for review the images afterwards. So we need a particular type of sequences. We need a high resolution images and high magnetic field. So not all the MRIs are the same. Not every MRI will have the same sequences. So we need to follow that kind of strict rule of what kind of MRI scan we use, what sequences we use. And also it's very important to follow the patients on the same kind of MRI because we are looking for new changes compared to the prior. So if somebody gets scanned somewhere else, which the sequences are different, the strength of the field is different, then it's going to be much harder to see the new changes compared to the prior MR. So it will be very important to have the follow-up with the same scanner, the same place, and make sure that we review them based on the protocol tightly.
The other thing we've talked about, Nasim, is when the scans will be read. How quickly will they be read after they're obtained?
Yeah, this is another thing that even if it's an outpatient, because we want to make sure that we see the changes pretty fast and inform the clinician, usually they will read within the first 24 hours as soon as the patient gets the scan. If they become symptomatic, then it's going to be in the first few hours. And then we will have a kind of a full circle of communicating with the clinicians who are seeing the patient. to make sure they are aware, and then there's going to be communication with the patients regarding that.
Question to you, John. Anticoagulation is a relative contraindication to get Leqembi. But what if a patient is getting Leqembi and then has symptoms of a TIA, a transient ischemic attack, or a small stroke? And normally we say, time is brain, go call 911, go to the emergency room to see if you qualify for getting TPA, which is a clot buster. It's a strong anticoagulant.
Right. Thanks for bringing up this important issue. So the symptoms of ARIA could look like a TIA, could suggest a stroke. And also people can have TIAs and strokes. And also the imaging characteristics, especially to the untrained of a scan, could look like changes of ARIA could look like some kind of edema from ischemia or something like that. So there's definitely the possibility of misdiagnosis and inappropriate treatment. So it's very important for anybody receiving these treatments to communicate to whoever they were to go see for a potential stroke that they're on this medication, because it could, like I say, lead to the inappropriate and even dangerous treatment.
So I'm going to end this section and turn to Dr. Aranda, but say that we now have 2 patients who are receiving Leqembi at USC, and in October we expect there'll be 3 more, and every week we're reviewing new potential candidates to receive Leqembi. All right, now for our last speaker, Maria Aranda, who's the director of the Alzheimer's Disease Research Center, OR Core, the Outreach, Recruitment, and Engagement Core. Dr. Aranda is a professor of social work at the USC Suzanne Dorick Peck School of Social Work, and she has a PhD, a master's in social work. She's also a licensed clinical social worker. Her own research studies have focused on depression and dementia and caregivers, and she is, as the director of the OR Core, helping us reach people outside our usual orb. Dr. Aranda, let's turn to you for our wrap-up.
Can you hear me now?
Yes.
Great, thank you. Well, hello and good morning. As Dr. Chu said, my name is Maria Aranda. It's an honor to be here today. I'd like to give a big thank you to Gail Batey and her family for supporting this participation appreciation event. All of you have had front row seats to this really premier event, specifically hearing about the state-of-the-art science on things like brain health, dementia, and groundbreaking treatments. I have several take-home messages for you today. First of all, we are eternally grateful to you. None of this exciting work would be possible if it were not for you, our study participants, our study partners. You have really given unselfishly to participate in our studies. Second, when you hear about brain health, memory research, the latest and greatest treatments in this space, think of USC. Think of USC Alzheimer's Disease Research Center. As you can see, our center is the hub of scientific discoveries that will change lives for not just now, but for generations to come. So really, we're paving the way for more accurate diagnoses, better treatments and care, and hopefully a cure. And lastly, you are our ambassadors. You are the center's ambassadors. And what does this mean? We ask you to continue to think about us, to continue to promote the studies and the clinical treatments that you've heard about today, and encourage your friends, your family members, your neighbors, your co-workers, your fellow congregants from your house of worship to engage with us about joining one or more of our studies or in our clinical treatment. When you think about participating in any study, whether it's at our center or anywhere else, we ask that you consider always the benefits and risks of participating in study activities. For example, on the left side here, some people encourage you to participate because there may be certain benefits in participating in a study. For example, the feelings of altruism and hope may be a consideration, or wanting to have an active role in your own healthcare, or having access to potential treatments or interventions before they're even widely available to the public, and also access to state-of-the-art information from leading experts like what you heard today. On this other side of this balance sheet, if you will, are the potential risks to participating in a research study. For example, sometimes we ask certain questions that you might feel are mildly discomforting, or side effects related to treatments or interventions. Some of those side effects were discussed today. Or potential risk is that maybe the treatments or interventions are really not effective for you or for your study partner. And there may be other risks that were not discussed today for other types of treatments in the future. And that depends, of course, on the nature of the study. You can have many studies to choose from here at the USC Alzheimer's Disease Research Center. And as you can see, we have multiple studies known by multiple titles or names. But feel free to look at the booklet that we provide you, understand the different descriptions of the studies. And if your interest is piqued, please make sure to call us, have a conversation with us about your interests, your preferences, your concerns, and we'll try to plug you into one or more studies. For example, I am a lead on a caregiver study. We are testing a series of online classes dedicated to family caregivers or care partners. The current science does indicate that caregivers experience high levels of psychological stress, physical stress, but also social and financial concerns. If you're interested, feel free to give me a call or send me an email. The study is fairly straightforward. We'll ask you to participate in online caregiver classes that are facilitated by a professional. And we'll ask you a series of surveys before and after the classes to see if the classes made a difference. The study is also described in your informational packet.